The AchilloCordPlus is a tubular tape intended to be used for the repair of acute Achilles tendon ruptures. The tape is made from densely woven polyester fabric and measures 5 mm wide by 800 mm in length. Both ends of the AchilloCordPlus are flattened and sealed, allowing it to be easily threaded through the eye of the probe and pulled through soft tissue and bone tunnels. We are going to demonstrate the repair of an acute tear of the Achilles tendon using the AchilloCordPlus. This technique allows the procedure to be completed by threading the AchilloCordPlus through the Achilles tendon using a small incision over the rupture and stab incisions laterally and medially to facilitate the passing of the AchilloCordPlus. To facilitate the repair, the AchilloCordPlus will be secured both proximally and distally to the site of rupture. Distal anchorage is formed by threading the AchilloCordPlus through a bone tunnel in the os calcis and a single pass through the distal tendon stump. Proximal anchorage is formed by passing the AchilloCordPlus through the tendon in a figure-of-8 fashion. The approximate distances for the proximal anchorage are 2 cm and 4 cm from the proximal end of the Achilles tendon. The AchilloCordPlus is tensioned and secured using a surgeon's knot. The knot is then buried in the soft tissue or within the Achilles tendon itself. To avoid damage, it is important to identify the sural nerve along the lateral border of the Achilles tendon during the procedure. A lateral view of the underlying anatomy emphasises how important it is to avoid going too deeply with the tape in the muscle or the tendon, as this may interfere with the blood supply of the injured area. This view also emphasises that the AchilloCordPlus should be threaded centrally within the tendon in the sagittal plane. The majority of the tape is contained within the tendon, resulting in less chance of adhesions. Prepare the patient in the standard way, confirming the injured limb. With the patient lying prone, exsanguinate the leg and apply a tourniquet. Sterilise the operative area. The recommended approach is through a posteromedial incision at the site of rupture, parallel to the medial border of the Achilles tendon. The underlying soft tissues are dissected to expose the site of injury. Confirm the pathology and identify the distal and proximal ends of the Achilles tendon. The alternative to this approach is to make an incision in the skin on the lateral site of the injury. Then pull this opening over to the medial side and make an incision through the subcutaneous tissues to the rupture. This technique helps to prevent deep infections, as once sutured closed, there is no direct route from the skin incision to the Achilles tendon. It also helps to prevent adhesions. The next stage is to make a transverse bone tunnel in the os calcis. The exits of the horizontal tunnel in the os calcis must be in line with the longitudinal axis of the Achilles tendon. The tunnel should be sited approximately 1 to 2 cm below the insertion of the Achilles tendon, thus ensuring a good bone bridge. Make a horizontal stab incision over the proximal os calcis to act as a pilot hole for the drill. Use a 3.2 mm drill to create the bone tunnel. Introduce the drill to the bone surface. Drill horizontally from lateral to medial. As the drill emerges at the lateral side, the skin will begin to tent. Use a scalpel to make a stab incision over the end of the drill bit, thus allowing the drill to exit. Pass the probe through the tunnel to the medial side. Thread the AchilloCordPlus through the eyelet of the probe on the lateral side of the leg. Tip: it is easier to thread the corner of the AchilloCordPlus through the eyelet first. Pull the probe through such that approximately 20 to 30 cm of the AchilloCordPlus emerges from the stab incision. Using the probe, make a subcutaneous tunnel from the medial stab wound to the centre of the distal end of the Achilles tendon. Keep the tunnel as close to the bone as possible. Pull the tape through so that it disappears under the skin on the medial wall of the os calcis. It is important to avoid catching the AchilloCordPlus on subcutaneous tissue around each stab incision. This can be checked by pulling on the AchilloCordPlus and confirming that there is no puckering of the skin. Should the skin pucker, then use an artery forceps to loosen the tissue around the AchilloCordPlus. Remove the probe and rethread it onto the distal end of the AchilloCordPlus. Again, use the probe to make a subcutaneous tunnel from the lateral stab wound to the centre of the distal end of the Achilles tendon, keeping as close as possible to the bone. Pull all the tape through so that it disappears under the skin on the lateral wall of the os calcis. The two ends of the tape are now exiting from the centre of the distal Achilles tendon. Tension the AchilloCordPlus so that it is positioned correctly. Hold the proximal end of the Achilles tendon with forceps. Pass the end of the probe through the proximal end of the Achilles tendon until it emerges about 2 cm proximal to the site of injury. Make a stab incision on the medial side of the leg over the end of the probe where the skin tents. Pull the probe and AchilloCordPlus through. Tip: it often helps to make a small stab incision centrally within the end of the tendon. This can be used to guide the probe to the correct location. Pass the probe through the first stab incision. Position the probe close to the exit point of the AchilloCordPlus. Pass the probe through the Achilles tendon to the lateral side about 4 cm proximal to the site of the injury, taking care to avoid the sural nerve. As the point of the probe can be seen tenting the skin, make a stab incision over the end of the probe. Pull the AchilloCordPlus through to the lateral side. It is important to avoid catching the AchilloCordPlus on subcutaneous tissue around each stab incision. This can be checked by pulling on the AchilloCordPlus and confirming that there is no puckering of the skin. Should the skin pucker, then use an artery forceps to loosen the tissue around the AchilloCordPlus. Continue by pushing the probe back through the stab incision horizontally so that it exits around 4 cm proximal to the site of injury on the medial aspect. Care must be taken to avoid trapping the sural nerve as the AchilloCordPlus is looped back through the Achilles tendon. Make a stab incision over the site of the probe and draw the AchilloCordPlus through the Achilles tendon. Going back through the third stab incision, push the probe through the tendon so that it exits about 2 cm proximal to the injury. Again, use the scalpel to make a stab incision over the end of the probe and pull the AchilloCordPlus through the Achilles tendon through to the lateral side. Finally, use the probe to draw the AchilloCordPlus from the lateral side distally through the proximal end of the Achilles tendon. Take care not to trap the sural nerve. Pull the two ends of the AchilloCordPlus to ensure the cord is seated tightly within the tendon with no slack. While the AchilloCordPlus is under tension, also confirm there is no trapped subcutaneous tissue by checking for puckering of the skin around any of the stab incisions. With the ankle in a plantar flexion position, tension the proximal end of the AchilloCordPlus to approximate the two ends of the Achilles tendon. Then pull on the distal end of the AchilloCordPlus so that any bunching of the cord at the rupture site is pulled taut. This will also pull the proximal stump closer to the distal stump. Ensure the length of the reconstruction is physiological and that the AchilloCordPlus is taut within the Achilles tendon. It is important to avoid over-tightening of the reconstruction or shortening of the reconstructed Achilles tendon, as the patient will have subsequent problems in regaining normal power and will continue to walk with an abnormal gait. When the preferred tension and length of reconstruction have been obtained, tie the two ends of the AchilloCordPlus using a surgeon's knot at the site of injury. Ensure that the knot is locked. Some surgeons may prefer a reef knot with or without an extra throw. In either case, it is very important to check that the knot is locked. Remove any excess AchilloCordPlus by cutting it straight across at right angles to its edge. This will minimize the generation of loose fibers. It is important that any loose fibers created when trimming to length are carefully removed. After trimming to length, it may be necessary to stitch the cut ends back to the cord. Ensure that the knot is well buried in the Achilles tendon or in the soft tissue. Use a strong, non-absorbable suture to stitch the ends of the tendon together over the top of the knot, so that the knot is covered by tissue and will remain buried. Perform the Simmons test to ensure adequate repair. Squeezing the calf muscle should result in plantar flexion of the foot. Where possible, use an absorbable suture with a running knot to close the sheath of the Achilles tendon. Wash the area with an antibiotic wash to minimize the risk of infection. With acute ruptures, there is usually no need to drain the wound. Close the subcutaneous tissue using interrupted sutures. Finally, close the skin incision using a continuous suture. Local anesthetic should be injected into the wound. Use steri strips to close the stab incisions if they are small, otherwise use individual sutures. Immobilization is not required for acute ruptures. The ankle should be covered with a wool and crepe dressing. Active and passive plantar flexion begins in the immediate postoperative phase.